Please go ahead. Okay, so good evening, everyone. On the behalf of Cipla Pharmaceutical, I, Kumar Kaushal, with my colleague, Mr. Sumit Srivastava, would like to welcome all the doctors in this meeting. Today's meeting is going to be a Rheuma-Derma interface meeting. For that, today we have with us 4 renowned doctors from different zones of India. First of all, please welcome Dr. Shyamashis Das. Sir is DM Rheumatology and he is a renowned senior rheumatologist from Kolkata with over 15 years of experience in rheumatology medicine. Sir is currently associated as a senior consultant rheumatologist with Institute of Neuroscience, Kolkata. Welcome, sir. Next, we have with us Dr. Debanjali Sinha. Ma'am is MRCP DM Rheumatology and working as a consultant rheumatologist at Institute of Neuroscience, Kolkata. Welcome, ma'am. From Uttar Pradesh, Lucknow, please welcome Dr. Sumit Gupta. Sir is working as a director and senior consultant at Dr. Gupta's Skin and Hair Hospital, Lucknow. Sir has more than 20 publications in national and international journals, and his clinic has received Best Skin Treatment Center Award by Honorable Health Minister and Deputy Chief Minister of Uttar Pradesh. Welcome, sir. Last but not the least, we have from Gorakhpur, Uttar Pradesh. Please welcome Dr. Sunil Kumar Gupta. Sir is working as an associate professor in the Department of Skin and BD AIMS Gorakhpur. Welcome, sir, in this meeting. So without making any further delay, first of all, I would like to invite Dr. Shyamashis Das to please enlighten us with your knowledge. Over to you, sir.
Thank you, Kaushal.
Welcome, sir.
Good evening, everyone. First of all, I'd like to thank Cipla for providing us this platform to discuss on an important molecule, that is secukinumab, in psoriatic arthritis, in ankylosing spondylitis, and psoriasis. My topic this evening will be secukinumab in ankylosing spondylitis, backed by long-term efficacy and safety data. We know that the recent EULAR criteria recommends secukinumab or IL-17 inhibitor, the first line biologic, along with TNF inhibitors in treatment of ankylosing spondylitis. So what is the evidence behind that? Is the evidence very sound, or is there any long-term evidence? What is the efficacy and safety regarding secukinumab in use in ankylosing spondylitis? We know that ankylosing spondylitis is a chronic inflammatory disease of axial skeleton characterized by progressive irreversible structural damage of sacroiliac and spinal joints, ultimately resulting in disability if untreated and reduced physical function and impaired quality of life. So being a chronic long-term disease, it warrants continuous treatment. Right now, the approved biological for treatment of ankylosing spondylitis in India are TNF inhibitors, namely infliximab, golimumab, adalimumab, etanercept. IL-17 inhibitors, only one molecule is available in India, that is secukinumab. Secukinumab is a purely human monoclonal antibody against interleukin-17A. It directly inhibits interleukin-17A. With the advent of TNF inhibitors over past couple of decades, these molecules have revolutionized the management of ankylosing spondylitis. TNF inhibitors significantly reduce signs and symptoms of ankylosing spondylitis, but like all medicines, all molecules, TNF inhibitors also have got their own limitations. TNF inhibitors have shown to be efficacious as it shows improvement of ASS40 response. Adalimumab shows 70. These are pooled data, not data from head-to-head trials. Pooled data from various trials show that adalimumab shows ASS40 response in 70% of patients. Golimumab 57% of patients showed ASS40 response, and with infliximab 63%. So 30 to 60% patients of ankylosing spondylitis are, we can say, non-responder to TNF inhibitors of various kinds. BASDAI 50 response with TNF inhibitors also between 60 to 77%. Again, for 30 to 40% patients do not show BASDAI 50 improvement. So these are the limitations of TNF inhibitors. Up to 40% patients do not respond or tolerate the therapy. Rapid relapse occur with discontinuation of therapy, absence of long-term remission. There is definitely risk of TB reactivation with TNF inhibitors, and there is high risk of immunogenicity. Anti-drug antibody formation is a common finding with TNF inhibitors. So, in management of ankylosing spondylitis, the potential benefits and risks must be assessed before initiating TNF inhibitors. So, let us have a look. What are the other alternatives to TNF inhibitors? Long-term efficacy of secukinumab in ankylosing spondylitis. Secukinumab is the first and only IL-17A inhibitor approved in India for management of AS. It was launched in India in 2017. However, secukinumab was approved by US FDA in 2015. And now we have 5-year long-term efficacy and safety benefit data of secukinumab in ankylosing spondylitis. Secukinumab have been tried in randomized control trials in biological naive patients and also patients with inadequate response to TNF inhibitors. So what are the long-term efficacy benefit and safety benefit of secukinumab in biological naive patients? 2 big RCTs are available with secukinumab in patients with active ankylosing spondylitis. First one is measure 1 and second one is measure 2. In measure 1, both of these were multi-center trials, randomized placebo-controlled trials. In measure 1, intravenous secukinumab loading dose was given with matched or matched placebo at weeks 0, 2, and 4, followed by subcutaneous secukinumab 150 mg or 75 mg or matched control, matched placebo every 4 weeks starting at 8 weeks. So these are the treatment protocol in measure 1. Measure 2, the difference was initial loading dose was given a subcutaneous secukinumab rather than intravenous secukinumab. 150 mg or 75 milligram, both were given in 2 arms or matched placebo at weeks 0, 1, 2, 3, 4, and then every 4 weeks. And these patients were followed up. The primary endpoint was ASAS20 response at week 16. And at week 16, patients in the placebo group were randomly assigned to subcutaneous secukinumab at a dose of 150 mg or 75 mg. And both of these, from both of these studies, RCTs, we saw that secukinumab at a subcutaneous dose of 150 mg with either subcutaneous or intravenous loading dose provided significant improvement. But secukinumab 75 mg only showed improvement with intravenous loading dose only. So right now, we use subcutaneous secukinumab loading dose followed by every 4 weeks subcutaneous secukinumab. However, as we have seen in future 4 trial in psoriatic arthritis, that even without the subcutaneous loading dose, secukinumab once every 4 week dosage is also almost comparable, at least statistically similar with the loading dose group. So, though we do not have data on this, I mean, without loading dose in ankylosing spondylitis, but in clinical practice, we often use secukinumab without loading dose in ankylosing spondylitis. So, what are the things we found from this measure 1 and 2 studies? It showed that there is fast relief of spinal pain, and that was an exploratory endpoint, and that showed improvement as fast as 4 weeks, 40% improvement as fast as 4 weeks, and that was maintained throughout 5 years. And measure 1 and measure 2, both patients were followed up in the extended study up to 5 years, and that improvement was maintained at 55% at the end of 5 years of follow-up. Sustained inhibition of disease activity in biological naive patients. that again showed very early improvement of BASDAI score as early as a few weeks, and that improvement of BASDAI maintained throughout 5 years. And that improvement of BASDAI occurred to the tune of 3.5, 3.7 of BASDAI score. And there was significant improvement of total spinal pain, morning stiffness, fatigue, joint pain or swelling, and enthesitis. And reduction is overall is that we see in segupilimab assessed by BASDAI. There was significant improvement of fatigue score. That was also evident in early weeks. Within 4 weeks, there was 31% improvement of fatigue, and that improvement sustained up to 5 years and sustained at the tune of 47% or nearly 50% improvement of fatigue score. There was again sustained improvement of signs and symptoms as assessed by ASS 20 and 40 response. There was also in ASS 40 response, we saw at the end of 5 years, there was 67% patient showed ASS 40 response and 78% showed ASS 20 response. So that was quite significant and impressive. Now, what about the data? What about the data regarding efficacy benefits of segupilimab in TNF inhibitor non-responders? In TNF inhibitor non-responders or inadequate responders, segupilimab also showed significant improvement of spinal pain score at detected by VAS, and there was improvement of 38 point of reduction of spinal pain in those group of patients, and that was the improvement was sustained throughout 5 years. Again, there was sustained inhibition of disease activity as assessed by BASDAI score in TNF inadequate response patients, and even within 2 weeks, these TNF IR patients, BASDAI improvement of 1.2 was observed within 2 weeks, and that improvement was sustained up to 5 years, and to the tune of 3.3 point improvement. Again, functional improvement was observed in TNF IR patients as assessed by BASFI, and that was also fast and sustained. There was sustained improvement of quality of life also as assessed by SF36 score. So we saw that in TNF naive patients and TNF IR patients, segupilimab showed significant improvement in disease activity and also functional score. There are some additional benefit of segupilimab, which is structural inhibition of structural progression. It has been seen from the measure 1 and measure 2 studies that patients with no syndesmophyte at baseline, after 2 years, 95% of patients remained free from syndesmophytes. And patients with syndesmophytes at baseline, after 2 years, 70% of patients did not develop additional syndesmophyte. And that was a very unique and important long-term benefit of segupilimab in ankylosing spondylitis patients. And even that inhibition of structural progression in AS patients was sustained throughout 4 years. And this graph shows that probability of non-progression of radiography score as assessed by MSAS was nearly 80%, after a follow-up of 4 years with treatment with segupilimab. This slide shows pooled data from various studies that inhibition of structural progression is segupilimab versus TNF inhibitors. And definitely this is an indirect comparison, no head-to-head comparison. And in this paper, the radiography progression in segupilimab or TNF inhibitors infliximab, OASIS and OASIS matched cohort were compared, and that showed that maximum inhibition of radiographic progression in ankylosing spondylitis occurs with secukinumab. And this graph shows a progression over 2 years, and and it has been checked in after treatment of 4 years as well, and it shows that TNF inhibitors had no effect on structural progression inhibition as compared to patients not receiving biologics over 2 years, and was even worse in patients receiving NSAID continuously for 4 years. That is an interesting finding, but we have to consider that these are not head-to-head trials, so different cohorts. So that we have to keep in mind. But this is definite that secukinumab demonstrate inhibition of structural progression at 2 years as well as at 4 years. Another interesting advantage of secukinumab over TNF inhibitors are low risk of immunogenicity. Immunogenicity of biological medicines are very important concern, because immunogenicity leads to loss of therapeutic efficacy as well as unfavorable safety outcomes. That means allergic reaction, and loss of therapeutic efficacy means with continuous usage, the efficacy or effectiveness of the medicine gradually goes off. So these two are very much, we are very much concerned about these two things. And an interesting study showed comparison of responding healthy donors T cell with different monoclonal antibodies. Immunogenicity of potential therapeutic antibodies was compared by evaluating the frequency of monoclonal antibody specific pre-existing T cell using an in vitro T cell assay. And in healthy donors, it has been shown that there is significantly less frequent T cell responses to secukinumab, indicating lower immunogenicity. Secukinumab shows the least responsiveness to donors, healthy donors T cells, compared with adalimumab, ixekizumab, and ustekinumab. Why this thing happens? That also was investigated in this study published in 2018 in Dermatology Therapeutics. That happens because significant lower number of pre-existing T cells to secukinumab compared with other three biologics, that is ustekinumab, ixekizumab, and adalimumab. The cause is not clearly known why this happens, but this is kind of how human body responds to secukinumab. This is a molecular advantage of secukinumab while being used in human body, that it produces less immunogenicity compared with adalimumab and ixekizumab. And it has been seen that anti-drug antibody formation with biologics in clinical trials is like secukinumab. With secukinumab, anti-drug antibody formation was less than 1%. Maximum being with infliximab 6 to 69%, followed by adalimumab 8 to 39%. So secukinumab has least formation of anti-drug antibodies, and and that is supported by the biological basis why this happens. So there is minimum risk of biological fatigue with secukinumab, and that less risk of immunogenicity is persistent through 5 years. Low risk of tuberculosis. Increased risk of TB activation is a major concern in anti-TNF alpha treatment, and in India, because TB is more prevalent in our setting. So with TNF inhibitor, this risk of TB reactivation is also a very major concern among us. It has been estimated that absolute risk per 100,000 general population for tuberculosis is 168. But the estimated absolute risk increase with use of TNF inhibitors per 100,000 population with adalimumab is 4,922, a huge increase, and infliximab 3,000 with infection 3,125. And it is supposed that even higher number of patients are at risk of developing TB in TNF with TNF inhibitors in India. That is a major advantage as we use secukinumab in this setting. Why TNF inhibitors causes TB reactivation? Because TNF inhibitors inhibit granuloma formation containing Mycobacterium tuberculosis, resulting in TB reactivation. However, secukinumab, the IL-17A inhibitor, have no effect on granuloma containing tuberculosis. So there is risk of TB reactivation is very low. And that happens because the unique mechanism of action of IL-17 inhibitor, it is not involved in the granuloma formation containing TB. And this property of secukinumab have been proven in vitro studies. Human in vitro granulomas containing tuberculous bacilli showed that chances of reactivation of tuberculosis with secukinumab is comparable with the control. However, the chance of reactivation of in vitro granuloma containing tuberculous bacilli is maximum with adalimumab, and that in vitro study corroborates with the tuberculosis, with the real life picture of increased risk of tuberculosis in patients treated with TNF inhibitors. Extension of phase 3 measure 1 study shows low risk of TB with secukinumab sustained through 5 years. Now, overall safety profile with secukinumab is also good. Serious infection, candida infection, Crohn's disease, ulcerative colitis, IBD class unclassified, and major cardiac adverse effects are also very not very increased. I mean, they're quite acceptable. And interestingly, less than IBD events, which is within expected background incidences. That is one concern, is that with use of secukinumab, there might be a flare of inflammatory bowel disease. However, as the data goes, data from the measure 1 and measures 2 study, it shows that occurrence of inflammatory bowel disease or flare of inflammatory bowel disease is not increased with the use of secukinumab as it is compared with the background incidence rate of IBD. However, secukinumab is not effective in active inflammatory bowel disease. So that has to be kept in mind. So in management of AS, secukinumab is the first IL-17A inhibitor approved, and it offers long-term efficacy benefit and safety benefit over a period of 5 years. Inhibition of structural progression over a period of 4 years, that is a unique and very important long-term benefit with secukinumab. There are some special situations, like if there is history of recurrent uveitis or active IBD, preference should be given to TNF inhibitors rather than secukinumab. But in patients with significant psoriasis, an IL-17 inhibitor, that is secukinumab, may be preferred as suggested in the Asas-Euler recommendation published recently. So thank you. With this, I will finish my talk. Over to Kaushal.
Thank you, sir. Next, I would like to invite Debanjali ma'am for her presentation.
Kaushal?
Yes.
Yeah, actually, we can take QA session in the last of the all talk. Okay? Because in chat box, there's so many questions. So question
Yes,
will take in the last.
Yes, we will be taking at the end.
Okay.
Right. So am I visible and audible?
Yes, ma'am.
Right. So my topic today is on the role of secukinumab, which is an IL-17 inhibitor, in psoriatic arthritis. Okay. So As we all know that psoriatic arthritis is a chronic immune-mediated arthropathy which is associated with psoriasis, and it is a multifaceted disease in which peripheral joints can be affected. Psoriasis can occur in the skin. There may be axial disease. There may be nail dystrophy. There may be enthesitis and dactylitis. Apart from this, there may be other comorbidities which may be associated with psoriatic arthritis like metabolic syndrome, obesity, and depression. So a large range of therapies has now been available for the management of psoriatic arthritis, starting from the conventional DMARDs like methotrexate, sulfasalazine, then the TNF inhibitors, IL-17 inhibitors, IL-12 inhibitors like ustekinumab, 23 inhibitors like guselkumab and risankizumab, and the recently newcomers JAK inhibitors like tofacitinib, and the PDE4 inhibitors like apremilast. But today's topic will be mostly on the IL-17 inhibitors and specifically on secukinumab. So as we all know, IL-17A is a very key cytokine, and it plays an important role in the enthesitis and structural damage. And the major sources of IL-17A cytokine is from the Th17 cells, gamma delta T cells, and ILC3 cells, that is innate lymphoid cells, 3 types. So IL-17A does not only causes bone erosion, but it also leads to bone formation, which is a characteristic feature of psoriatic arthritis. So basically, IL-17A, it stimulates the rank ligand, which helps in the differentiation of osteoclasts, and finally it leads to bone erosion. On the other hand, it also helps in bone formation because it leads to the differentiation of osteoblasts from mesenchymal stem cells, and via stimulation of signaling molecules like WNT and BMP, it helps in the production of new bone. It helps in new bone formation from the osteoblasts. So there are a few studies like the Future 1 to 5, Maximize, and the Exceed studies, which has been done in of secukinumab and psoriatic arthritis, which we will be discussing now. So first, coming the Future 1 study that had randomized patients into 3 arms. The first arm was secukinumab 10 milligram loading dose IV at 0 to 4, means a 2 weekly interval for 2 months, and followed by secukinumab 150 milligram subcutaneously 4 weeks or 1 monthly interval. The second arm was again the same loading dose intravenously for 2 months, followed by 75 milligram of secukinumab monthly. And the last arm was placebo arm, in which at 16 to 24 weeks, placebo patients who were receiving placebo were switched over to secukinumab. So that was 16 weeks in patients who were non-responders to placebo, and 24 weeks in patients who were responders to placebo. And this trial went on for 52 weeks. The next study was the Future 2 study design. In this, patients were randomized into 4 arms. So here there was no IV loading dose. Rather, the patients were loaded with subcutaneous secukinumab. So in the first arm, secukinumab high dose 300 milligram was used subcutaneously weekly for 4 weeks. And then it was followed by 4 weekly intervals subcutaneous 300 milligram secukinumab. The next arm was subcutaneous 150 milligram weekly for 4 weeks, followed by 4 weekly 150 milligram secukinumab. And the third arm was secukinumab 75 milligram subcutaneous loading dose, followed by at 4 weekly interval. And the fourth arm was placebo, which was switched to secukinumab in the same way in which it was done in the Future 1 study. And the inclusion criteria for both the Future 1 and both Future 2 studies was that it had to be an active psoriatic arthritis with at least 3 tender or swollen joints in the patients. And there may be inadequate, the patients need to be inadequate responders to methotrexate and may be inadequate responders to anti-TNF therapy. So coming to the first, the primary outcome in both the Future 1 and Future 2 studies, it was found that secukinumab, so here we can see that the blue one, the light blue color, is the secukinumab 150 milligram, and the purple is the secukinumab 75 milligram, the future one. And similarly in future 2, we can see that the blue is the 150 milligram and the green is a 300 milligram high dose. So in both the future 1, future 2 studies, we find that there were superior responses with secukinumab any dose versus placebo and at 24 weeks. And there was also superior ACR 50 and 70 responses with the secukinumab at week 24, and this ACR response was sustained through week 52, not only for ACR 20 but also for ACR 50 and 70. This is in the future 1, and the similar thing in future 2 was also seen. So here we can also see that in the 75 milligram, okay, so here just one thing we would like to say, the 75 milligram subcutaneous dose, which was used in the future 2, that was not very significantly more with as compared to the placebo arm regarding the ACR 50 and 70 responses at week 24. But when we are seeing at week 52, at the end of 1 year, the 75 milligram secukinumab arm is gradually rising, and it's almost similar to the other doses of secukinumab. Coming to the PASI assessment in both future 1 and future 2 study, again both the secukinumab doses had superior PASI 75 responses at week 24. But one thing to be mentioned, in all amongst all the secukinumab dose, the 75 milligram secukinumab dose did not significantly improve PASI 75 response versus placebo. It was just 28% versus 16.3% in the placebo. So here we get an idea that 75 milligram dose may not be very good for skin, but it fares more or less well for joints. Okay, so coming to dactylitis and enthesitis also, secukinumab had improved dactylitis and enthesitis at week 24, as we see in both the future 1 and the future 2 studies. Coming to the joint structural damage, the future 1 assessed radiologic progression in secukinumab arms, and it was found that yes, secukinumab did significantly inhibit progression of joint structural damage at week 24, because as we found that the mean change from baseline in the mean total sharp score was significantly less as compared to that of the placebo. Just one second. Okay, so here again we see the future 1 study that secukinumab inhibited the joint structural damage around in the secukinumab 75 and the 150 milligram arm. About 82 to 92% patients had non-progression of the total sharp scope from baseline at 24 weeks, whereas around 75% had no progression in the placebo arm, and this was significant. And this inhibition was maintained till week 52. Another interesting thing was that secukinumab improved not only the in anti-TNF naive patients, when it was tried in both the arms, like anti-TNF naive patients and anti-TNF inadequate responders, secukinumab improved ACR responses in both the arms. Here we see that this is for the future. The previous one is the future 1 study, and the future 2 study also, it was found that in both anti-TNF naive and inadequate responders, secukinumab had improved ACR responses at week 24. And it has also found that secukinumab improved ACR 20 responses with and without concomitant methotrexate use. Coming to the safety data, in both the future 1 and future studies, there were 3 common adverse effects: nasopharyngitis, upper respiratory tract infections, and headache, which was significantly more in the secu arms as compared to the placebo. Amongst specific infections, candida infections was found to be more common in these patients receiving secu, but versus placebo. As elaborated by Dr. Shamashri Dash, definitely IBD was not found to be in such high extent as it was thought to be before. It was first found in 2 patients in patients receiving secukinumab versus 1 in the placebo arm, which was not very significantly increased. So conclusions from the future 1 and 2 studies: that secukinumab definitely reduced signs and symptoms of psoriatic arthritis And it also improved not only ACR 20, 50, and 70 responses, but it also improved the PASI responses, the physical function, enthesitis, dactylitis, and quality of life. It also led to radiographic disease progression halt, and effective in both anti-TNF naive and anti-TNF inadequate responders, and it was without concomitant methotrexate. Secukinumab was found to be helpful. It was very well tolerated and without any unexpected safety findings. Coming to the Future 4 study. So here there were 3 arms. So this is very much important in our scenario in patients with where financial constraints are there with the patients. So this is relevant in such situations in like countries in India. So here there was it compared loading versus non-loading, and not with the 150 milligram of secukinumab, it did not use the 300 milligram. So what it did was, in the first arm, 150 milligram of secukinumab was loaded at weekly interval for 4 weeks, and it was followed by every 4 weeks interval. The second arm was 150 milligram no load. So, and then it was given at baseline, and then it was followed by secukinumab at every 4 weeks. So 0, 4, 8 weeks in this regimen, the patients received secukinumab. And in the third arm, the patients were on placebo. So in this, it was found that in both the loading and the non-loading groups of 150 milligram secukinumab, ACR 20 responses at weeks 16 was comparable, being 41.2 and 39.8% respectively. And in earlier and in the loading secukinumab dose, it was found that the responses were a bit earlier, and numerically higher response was seen in the secukinumab load arm at week 16. For only some of the clinically relevant, difficult to achieve endpoints like ACR 50, PASI 90, minimal disease activity, these. But for ACR 20 and PASI 75 responses, the responses were comparable. And it was also found in patients who were not responding to a 150 milligram of secukinumab dose, upon dose escalation to 300 milligram of secukinumab, the patients definitely improved. So here we get to learn that even without loading dose, with a moderate dose of secukinumab of 150 milligram, the patients, if they may respond a little bit late, but definitely has comparable response to the as compared to the loading dose. So definitely it cuts, it helps in saving money for the patients who are taking scaffold. The next one is a Future 5 study. It is mainly focused on the rates of radiographic progression in psoriatic arthritis, 52-week data. Here again, secukinumab 300 milligram was used in the first arm with loading, followed by 300 milligram for weekly interval. Then secukinumab 150 milligram with loading, followed by 150 milligram 4 weekly interval, and the third arm was 150 milligram without loading, followed by 150 milligram 4 weekly interval, and of course the fourth arm was placebo. Here also it was found that majority of the secukinumab treated patients, about 85 to 92% of the patients, they did not show any radiographic progression as at week 52 as compared to patients who were receiving placebo, and this was same for the no load group as well. And this is again like compared between anti-TNF naive and anti-TNF inadequate responders. They divided the patients. It was found that yes, even in anti-TNF inadequate responders also, the radiographic progression could be halted by the use of secukinumab. So this trial concluded that yes, secukinumab not only 300 milligram but 150 milligram without load can also provide sustained low rates of progression through 52 weeks of treatment, and with around 85 to 92% showing no radiographic progression at week 52. And a 2-year extended trial was also done of the long-term Future 5 study, which was also similar, and it was found that about 90% of the patients did not show any radiographic progression at 104 weeks, that is 2 years. And it was same for this slide is on anti-TNF naive. Around 93% had no progression, and anti-TNF inadequate responders around 80% did not have radiographic progression. Coming to the last 2 trials, the Maximize trial. So this is the only RCT done of in axial psoriatic arthritis. So till now, no RCT is there, even on TNF inhibitor in axial psoriatic arthritis. So here the patients were included who had psoriatic arthritis with active spinal disease. And active spinal disease, how it was defined by the physician, and had a Barzai score more than equal to 4 and a spinal pain score more than equal to 40. So, and it had to be an inadequate responders to at least NSAIDs, 2 NSAIDs over 4-week interval. So the trial design was how the patients were randomized into 3 groups: 300 milligrams SECU, 150 milligrams SECU, and placebo. In both the SECU arms, loading dose was used. So here it was found that definitely both the doses of SECU that significantly improved ACEs 20 response versus placebo at week 12. And it was the response was also sustained through week 52, as we can see in this diagram. Coming to the last trial, the EXCEED study. So EXCEED study is it basically investigated whether secukinumab 300 milligrams monotherapy is superior to adalimumab. It's a head-to-head trial between secu and adalimumab. So here it was used as biologic was used as first line therapy, and this is a fully blinded trial, not an open label one, but it is the first head-to-head trial in psoriatic arthritis. Two things to be kept in mind. First is, in this secukinumab 150 milligram was not used, only the high dose of secukinumab was used. And the second thing, all the conventional DMARDs were stopped during the study. So the patients were kept either on secu monotherapy or adalimumab monotherapy. Of course, NSAIDs and low dose steroids were allowed. So here the patients included what were active psoriatic arthritis, defined by at least 3 tender rod swollen joints, and the patients also needed to have active psoriasis, at least 1 active psoriasis more than 2 centimeters, or nail psoriasis or plaque psoriasis, with previous inadequate responders to conventional DMARDs. So here, this is the study design. As we can see, it was randomized patients were randomized to two groups. One was secukinumab 300 monotherapy. The next one was adalimumab 40 milligram at 2 weekly interval, and 300 milligram secukinumab was given with loading. Okay, so the primary outcome, it was found that the primary endpoint of superiority of secukinumab versus adalimumab for ACR 20 response at week 52 was not met, but the responses were comparable. Around 67% of patients in the secu arm achieved ACR 20 response at week 52 versus 62% in the adalimumab group. However, significantly higher patients on secukinumab had a higher treatment retention rate than adalimumab. So this was important, and in some recent meta-analysis in psoriatic arthritis, it has also been found that amongst all biologics, secukinumab was associated with the highest treatment retention rate, possibly because of its lowest chances of adverse events. So in this trial, in the EXCEED trial, it was found that though secukinumab did not achieve superiority of over adalimumab at week 52, so the ACR 20 response was comparable between the two arms at week 52, 67 versus 62%. But if the ACR 50 and the PASI 100 response was combined, so in such situation, secukinumab definitely had better response as adalimumab. Though it was not significant, statistically significant, p-value being 0.06, but the response was of secukinumab was better than adalimumab. So as we can see in this study, other endpoints were also tried, like ACR 20 and 50 response, and PASI 90 and 100 response. In all these outcomes, secukinumab fared better than adalimumab, but not statistically significant. Some other outcomes were also studied in this EXCEED trial, like the DAPSA remission, PASDUS remission, HAD-TS. So these were very stringent criteria. So in all of these, we find that definitely secukinumab, the numbers are better and higher than adalimumab, but the p-value was not significant in any. So here we concluded that in patients of this subpopulation of psoriatic arthritis who has active psoriatic arthritis plus concomitant skin disease, secukinumab definitely provided higher response compared to ADA at week 52 in achievement of simultaneous improvement of joint and skin disease, and in the other efficacy endpoints. So recently there is a meta-analysis done by a Chinese group that pooled data from future 2, 4, 5. Basically, they tried to compare the secukinumab 300 milligram to 150 milligram. So in this, it was found that at week 24, secukinumab 300 milligram was associated with a higher ACR 20, ACR 50, PAS 75 response, and dactylitis resolution rate than secukinumab 150 milligram. But this effect was especially seen in patients who were anti-TNF inadequate responders. This is first, and secondly, at week 52, it was also found that secukinumab 300 milligram was associated with a higher PASI 75 and 90 response rate than secukinumab 150 milligram. So it was extrapolated from this meta-analysis that in two situations we need to use secukinumab 300 milligram over 150 milligram. First, in patients who had failed anti-TNFs, who were inadequate response to anti-TNFs, and second, patients who have extensive skin psoriasis, and we need some early response regarding skin. So apart from these two conditions, we may very well go ahead with 150 milligram with or without loading. So this information is good for our Indian patients so that it saves some money for the patient. So finally, to conclude and to summarize, secukinumab, as we have seen, it provides early and sustained benefits across all the 6 main clinical manifestations of psoriatic arthritis, psoriatic disease rather. Over 80% of patients achieve remission of peripheral arthritis. About 66% achieves PASI 90 response with secu over, and it was evident over 5 years also. It has been studied that it works well. Over 89% has resolution of dactylitis. Over 73% has resolution of enthesitis at 2 years. The Maximus trial has shown that significant number of patients has improved ACS 20 and 40 response, and even in skin we see that significant and visible improvement in NAPSI score around 63.6% has been found as far as 2.5 years in patients with psoriasis. So with this, I would like to end my talk. Thank you so much to everyone.
Thank you very much, ma'am, for the detailed presentation. Now I would like to invite Dr. Sumit Gupta, sir, to please enlighten us with your knowledge. Over to you, sir.
Thank you, Sipla, for giving me this invite. I must congratulate the rheumatologist from Kolkata, Dr. Devasis and Dr. Debanjali, for their excellent lecture. I may also congratulate Dr. Sunil Kumar Gupta, my dear friend, who has been selected for the second international training program by the Ministry of Science and Technology of China to attend the program in China.
Thank you,
congratulations
Sumit.
to all of them.
Thank you, Sumit. Thank you.
Thank you, bye. Congratulations a lot. I'll be covering, I'm a dermatologist from Lucknow, and I'll be covering the skin part for Is my screen visible?
It's still loading, sir.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Thank you so much. So the role of interleukin 17 inhibition in psoriasis. Disclaimers. So psoriasis affects almost 25 million people at present, and 20% of the global disease burden is in India now. And out of this, 90% patients plaque psoriasis, which are approximation, and males are about 2 times more commonly affected than females. So history of psoriasis: previously psoriasis was considered a part of leprosy. It was a form of leprosy, but later on Dr. Hebra used the term psoriasis in 1941, and later it was found out in 1960 it is a disease of epidermal proliferation. In 1980 it was disease of immune system, and now it is considered as systemic disease with comorbidities. So it just appears like a skin disease, but can it be treated by topicals? So we have to understand the progressive systemic inflammatory skin disease, which is psoriasis, which has visible manifestations and invisible manifestations with comorbidities and impact on quality of life. So the visible manifestations are scalp psoriasis 88%, nail psoriasis 74%, palmoplantar psoriasis is 59%. And invisible manifestation includes psoriatic arthritis, which is 30 to 41%, dactylitis 50%, spondylitis 5 to 25%, and enthesitis is 67%. Along with this, we have found that psoriasis is also associated with comorbidities, which includes depression, which is 79%, CVDs 13%, diabetes 42%, metabolic syndromes 8 to 60%, and obesity 32%. So this is as per the Indian study analysis. 32% has at least one, 10.8% had two, 8.5% have more than or equal to three comorbidities. So now psoriasis is just not considered as a skin infection, it is associated with comorbidities as well. So effect of psoriasis in patients, the quality of life. 75% patients said that is moderate to large negative impact on quality life, and 60% said they are missing almost 26 days per year after their work when they are having psoriasis. So quality of life is significantly impaired, where 94% people says that psoriasis is a problem in my daily life. 88% says psoriasis affects an overall emotional well-being, and 82% says psoriasis interferes with my enjoyment of life. So treatment options include topicals, phototherapies, systemics, and biologics. So high level of dissatisfaction with traditional therapies are seen amongst the patients, which is 52.3% were dissatisfied with the treatment of psoriasis. It is recurring and patients are getting those lesions again and again. So when we compared with topical therapy, with the phototherapy, with the traditional systemic therapy and biologics, we found that topical therapy patients were really very much dissatisfied. The satisfaction percentage was too less. Whereas with biologics, the satisfaction level has gone up to 36 to 52%. So more than 50% of the patients reported very high treatment satisfaction with biologics. So biologics also meets the aim of current treatment approach. So it's ameliorate the course of the disease, prevent relapse, and improve overall prognosis by reducing the disease severity, and helps in a long-term remission. So treatment with biologics is often undertaken with topical agents, and systemics have provided unsuitable even in patients with moderate to severe disease. And delay in biologic administration may affect treatment outcomes. So as soon as we inject biologics, that will be a better option rather than delaying it with traditional topical therapies and oral therapies. So we have found that early and more effective treatment of psoriasis with biologics may provide long-lasting benefits throughout patients' lives by improving skin symptoms also, and reducing systemic inflammation and comorbid progression as well. So IPC 2020 also recommends early uses of biologics. So patients should always be classified as candidates for topical therapies or systemic therapies. But when there is a failure to response, then biologics should be given as the first choice drug. So summarizing the need of early use of biologics, it improves the prognosis, controls over the symptoms, long-term remissions are there, high efficacy and favorable safety are there, and better quality of life are being given to the patients. So we have biologics which are TNF inhibitors, which are etanercept, adalimumab, infliximab, And then there's interleukins inhibitors, which is secukinumab and izixicumab. Secukinumab is the first interleukin 17A inhibitor which is available in India for the management of psoriasis. So visible manifestations, if we come to see, and the role of secukinumab, we see that efficacy in skin symptoms, PASI's 90% response is seen on almost 72 to 65% patients. As early remission is seen in 12 weeks time with 72%, and this goes a long way up to 52 weeks. The remission stays as PASI's 90% is achieved. Whereas we compared with etanercept, the remission rate is 53.8%, which is quite less than secukinumab. Efficacy in scalp psoriasis. Again, PASI's 90 response is seen in almost 58.8%, with early patients be seen at 12 weeks. Secukinumab is given in 300 milligrams. In nail psoriasis, NAPSI's response, as early as week 16, we get a response of 45.6 PASI's, 100% improvement, whereas by the week of 132, we are seeing a PASI's response 100% by 73.3%. Efficacy in palmoplantar psoriasis, we are seeing that even we inject 150 milligrams or 300 milligrams, 300 are showing a better result initially, but at the end of 132 weeks, both 150 milligrams and 300 milligrams are almost similar results, with 52% and 59% subsequently of 150 and 300 milligrams of secukinumab. Now coming to invisible manifestations, I think the rheumatologists have already talked about a lot, so I'm skipping the part. Coming to secukinumab with comorbid conditions, the effect on CVD risk is quite high when patient is suffering from psoriasis. So when patient is on secukinumab, the group 1, if you can see, it shows 1.7% increase in the FMD. FMD is an early predictor of CV disease, and 1% or more increase in FMD denotes a 13% decrease in CV risk. So if we are finding FMD as high as 1.7% in 52 weeks, that indicates 22% reduction in CVD risk. So we have a good chance of early diagnosis and prevention of CVDs when we are giving secukinumab. Coming to metabolic syndromes, we have found that 3 studies were there, and the pooled data was analyzed with fixtures, erasures, and sculpture studies in plaque psoriasis 45 patients population. And following parameters were included: triglycerides, HDL cholesterols, LDL cholesterol, fasting glucose, and body weight. So what we found? We found the lipid parameters were almost stable up to 52 weeks with secukinumab, with no consistent pattern of increase or decrease. So that was a quite healthy and heartening effect. Again, with the body weight, we found it is associated with slight reduction in the body weight at 52 weeks of treatment, whereas etanercept showed a trend towards an increase in body weight. On fasting plasma glucose, secukinumab showed a trend towards lowering fasting plasma glucose levels compared to placebos. Coming to the role of secukinumab in quality of life. So the improvement in quality of life is as high as 57% at 12 weeks, and as high as almost 80% of patients having 300 milligrams of secukinumab, which is at 52 weeks. So this is quite a remarkable achievement, at 80% having a good or improved quality of life. So the improvement of quality of life is sustained throughout the 5 years with secukinumab. So I know it's an expensive molecule, but 5 years remissions or 5 years improvement of quality of life definitely works. I have my patients which says, सर मैंने इसको पहले क्यों नहीं ले लिया, अगर मैं इसको पहले ले लेता तो मैं शायद मेरी 10 साल मैं और बेहतर जी सकता था. So these are the statements which are made by my patients when we give secukinumab. One more change which I have seen is though the studies does not agree with that, but with weight gain and obese patients, the higher levels of secukinumab, which is going up to 450 milligrams, I have seen good reductions in psoriatic patches and a good level of decrease in the nail patches which are seen. So if we are giving a higher level in obese patients which are more than 70 kgs, 80 kgs, then it definitely works for them. So in conclusion, psoriasis is more than a skin disorder and associated with visible manifestation, invisible manifestations, comorbid conditions, and impaired quality of life. And whereas secukinumab helps in managing psoriasis beyond the skin. So that's from my side. Thank you so much.
Thank you very much, sir. Now I would like to invite Dr. Sunil Kumar Gupta. Please enlighten us with your knowledge. Over to you, sir.
Thank you, CIPLA people, for giving me opportunity to present here on the important topic biologics in psoriasis, specifically with 17 interleukin 17A. And as the Dr. Das, Dr. Sinha, and Dr. Sumit presents very well insight about this molecule in the management of psoriatic arthritis and psoriasis. So with that, I am presenting my part. Is it my screen is visible?
No, sir.
Not now, Sunil.
I think, sir, Dr. Sumit, you should stop the sharing your screen. Then he can
I've
share.
stopped it. I think it's.
But it's the featuring, sir.
Okay. Let's start it.
Now visible?
No, sir. Before I stop, yeah. Now it's visible, sir.
Okay. So, as the topic is choosing a biologic in psoriasis, secukinumab versus TNF inhibitors, and I am seeing here in the chat box there are different questions on this. Why we are using secukinumab and why not TNF alpha inhibitors? So there are so many data that represent why secukinumab is superior than other biologicals, specifically that inhibits the TNF alpha. So as we know that psoriasis is a chronic skin disease, and now this is not only a skin disease, but the metabolic syndrome and is an autoimmune disorder. So a multidisciplinary approach with a targeted treatment is required for the long-standing remission of the disease. And it is one of the important disease that we see in our day-to-day practice. Why the patient expect treatment in psoriasis? There are so many reasons. The most important thing is the social stigma related with the skin diseases. And second is, the recurrence of the disease. Because what happens, the patient of psoriasis is suffering from sometimes, the hair, scalp, nails, and skin diseases, and also with the arthritis. And such patients are very depressed due to the cutaneous presentations. So they required a treatment that is very compatible for their daily life and give early clearance and maintain for a longer durations. So that's why such patients need a very good treatment. So there are different options for the management of psoriasis. We already know from the topicals, phototherapy, and systemics and biologicals. And even the NICE guidelines say that if we choose the treatment, we should start from the topicals and then move from the systemic immunosuppressive drugs and then to the biologicals and to shift to other higher types of, the biologicals. But this is not always followed, because sometimes what happens, NICE guidelines say that if the disease is BSA is more than 10% or PASI is more than 10%, 10, then we will choose the biologics. But what happens if patient is suffering from, depression, or if the disease is present on the exposed part of the body that affects the daily quality of life of the patients? So in such situations, we need a very good drug that clear the lesions very fast and maintain for the longer durations. So what are the advantages of these biologics if we choose early? It controls all over the symptoms, give a long-term remissions. It also give a better quality of life. As we know, it has a high efficacy and favorable safety. So it have a very good prognosis. In India, the approved biologics are in two groups, TNF-alpha inhibitors and interleukin-17A inhibitor. And the 17A inhibitor, secukinumab, is the prototype. And we are usually use this drug very frequently for the management of psoriasis and psoriatic arthritis. As there is a questions in chat box, what is the mechanism of actions? This diagram show very clearly how secukinumab acts and prevent the development of the disease or help in the clearance of the lesions. If you see, regarding these are the TNF-alpha inhibitors like adalimumab, infliximab, and etanercept. These basically block the TNF-alpha that activate the dendritic cells. And these dendritic cells basically stimulate the Th17 cells to increase the keratinocyte layers. And this stage is blocked by secukinumab because this phase from Th17 cells to stimulation of the keratinocytes proliferation is directed under the influence of interleukin-17A. But this is not only the step. Another step is that secukinumab also control the keratinocyte proliferation with controlling the interleukin-17A overexpression. And then we will see that the thickening of the skin of plaques decreased and also the inflammation of the lesion decreased. So what parameters will decide the choice of biologics? Sometimes we ask, why we choose? We choose on the basis of rapid onset of the response, superiority of response, quality of life improvement, and number needed to treat the disease, and of course, the safety concern. The rapid improvement of psoriasis should be considered as an important factor in treatment selections. So when we need these conditions, we should choose a good drug. Now, there are some trials that compare the interleukin-17A inhibitor to other TNF-alpha inhibitors like infliximab and adalimumab and etanercept. And this show that secukinumab offers the fastest actions in achieving PASI 50. There was a fixture trial, phase 3, that was a double-blind randomized control trial evaluating the efficacy of secukinumab and etanercept in moderate to severe psoriasis patients. In this phase trial, 1,306 patients were randomized assigned in 1:1:1:1 to secukinumab 330 milligram, secukinumab 150 milligram, and etanercept and placebo. And the result was that secukinumab give the fastest speed of response. Another effect on skin symptoms like achieving the PASI 75. The systematic review and network meta-analysis show that secukinumab had 81.9% probability of achieving PASI 75, which was highest as compared to TNF-alpha. If we see this regarding the TNF-alpha inhibitors with PASI 75 response, etanercept just 57.5% and adalimumab 68.9% and infliximab 74.3%. So now, after PASI 75, when we talk about the more clearance of the disease, that is the PASI more than 90% clearance, the 90% patients value clear skin as one of the most important treatment outcome that was not seen with other biologics. So this influences the outcome because it increases the work productivity, quality of life, and in reduction of work impairment, and it's improved the condition of the patients. So European Medicine Agency approved these interventions of interest at their licensed doses. That a systematic review and network meta-analysis on this PASI 90 response show that secukinumab gives 66% probability to achieving this PASI 90, which was highest as compared to TNF inhibitors. The closest TNF-I was infliximab that gave the 56%, but the result was significant when we talk in comparison with secukinumab. Other was, now we talk about the PASI 100 response. This PASI 100 we talk with secukinumab, because secukinumab is the drug that gives 40.6% probability of achieving PASI 100, which was highest as compared to other TNF-alpha inhibitors. So these are the some factors like that. Absolute PASI less than 5 points, a strong indicator of the achievement of long-term psoriasis control. The effect on skin symptoms like absolute PASI response. There was a study, Sculpture, that was a phase 3 multicentric randomized controlled trial, and patients who completed 52 weeks entered the extension phase and continued till 5 years. 168 patients entered the extension phase and 126 completed the 5-year treatment period. The observational, retrospective, single center study to compare absolute PASI score in moderate to severe type of plaque psoriasis patients treated with etanercept and adalimumab, and they found that 1.5 times more patients achieve absolute PASI less than 5 with secukinumab as compared to TNF inhibitors. So psoriasis has a significant negative impact on patients' health-related quality of life, and this necessitates to assess the ability of biologics to improve patients' quality of life. For that reason, there was another systematic literature review that was conducted to identify the phase 3 double-blind randomized controlled trials for the adult patients with moderate to severe psoriasis, and DLQI 0/1 was assessed at week 12. And the researcher found that secukinumab had the highest rank in achieving DLQI as compared to TNF inhibitors. And also, if we talk about the prospective cohort study, that is by the B, evaluated health-related quality of life, the European Quality of Life 5D with etanercept and adalimumab was assessed at week 24. And PROS was a prospective non-randomized multicenter study in which a European Quality of Life 5D with secukinumab was assessed at week 16. And the result was that secukinumab had the highest efficacy across all the domains of European Quality of Life 5D response as compared to TNF inhibitors. So in terms of that, psoriasis, secukinumab also improved the quality of life in compared to other TNF inhibitors. What are the number required to treat the disease? If the number need to treat decrease, it means the drug is very effective. So lower the NNT, the more likely a treatment will achieve the specified outcome in an individual patients. NNT for PASI 75, 90, and 100, when we talk on this and compare the secukinumab versus other TNF-alpha inhibitors, we will find that secukinumab had the lowest NNT, indicating highest ability to achieve PASI 75, either PASI 90 or PASI 100 as compared to TNF inhibitors. Now, assessing the safety profile of a biologic is important in management of psoriasis. Yes, of course, safety concerns with tumor necrosis factor inhibitors are very serious. TNF inhibitors are contraindicated in patients with chronic leg ulcers, persistent or recurrent chest infections, indwelling catheters, demyelinating diseases, congestive cardiac failure, malignancy. There is a risk of TB reactivation, and this is a serious issue in countries like India. And also the risk of immunogenicity. The major risk of serious infections with TNF inhibitors are that bacterial infections like tuberculosis and other bacterial infections, deep fungal infections, viral infections like hepatitis B, C, and HIV, and sometimes parasitic infections like toxoplasmosis, strongyloides, and leishmaniasis. These are the important issues that we should take care when we give TNF-alpha inhibitors. But this is very less in terms of when we use secukinumab, because secukinumab has very less chance to associate with such serious infections. But of course, it is also associated with candida infections, some of the inflammatory bowel diseases like Crohn's disease and ulcerative colitis, and of course the neutropenia. But the most important adverse effects is the URI, upper respiratory tract infections. When we compare the safety profile of secukinumab versus TNF-alpha inhibitors, the most important thing in India is the reactivation of tuberculosis. And this reactivation of latent tuberculosis is high when we use biologicals like TNF-alpha inhibitors. Why? Because TB risk is an important consideration. TB reactivation is a serious concern in patients undergoing immunosuppressive treatments such as biologicals, and the increased risk of TB, as already I told, it is a major concern with anti-TNF-alpha treatments. There was some data that showed that in a study reported by Navarra et al., India ranked 7th out of 15 Asian countries in the terms of absolute risk of TB with use of anti-TNF-alpha agents. In my personal own experience, I am using adalimumab frequently, and I also using secukinumab, and I found 4 cases of psoriasis who developed tuberculosis after 5 doses. So this is a very serious concern. So if we plan for TNF-alpha inhibitors in psoriatic patients or in other skin conditions, we must rule out tuberculosis and even the latent tuberculosis. There is, as I hear, in this study, estimated absolute risk of increase in TB per 100,000 was that 4,922 with adalimumab, as I already told. This is a very high number. 302 with etanercept and 3,125 with infliximab. This data, why with adalimumab? Because adalimumab in TNF-alpha inhibitor is one of the drug that is easily given because it is given most of the subcutaneous. This cytokine TNF and interleukin-17 play an important role in immune response against tuberculosis. So risk of TB reactivation when we compare with secukinumab and TNF-alpha inhibitors, TNF-alpha inhibitors increase 27 times of reactivation, while interleukin-17A inhibitors lower risk of tuberculosis reactivation because it enhances apoptosis of the Mycobacterium tuberculosis infected macrophages, limiting the intracellular growth. This bar diagram showing that the increased staining of aramine O, decreased staining of Nile red bars that indicate that reactivation of the Mycobacterium tuberculosis, and the increased risk of tuberculosis reactivation with adalimumab, etanercept, while secukinumab has no effect on TB dormancy, indicating low risk of TB. It doesn't mean that if the patient is suffering from latent tuberculosis, you directly give the secukinumab, but you should treat the disease. The occurrence of URTI, when we compare this secukinumab versus TNF-alpha inhibitors, secukinumab has the least rate of URTI in comparison to TNF blockers. And TNF blocker, this is a black box warning concerning infections. Now, another important thing is the immunogenicity, development of antibody against the biologics. Immunogenicity is an important consideration in choosing a biologics. You know, you neutralize the efficacy of the biologicals. So this impact of immunogenicity had different role, like on pharmacokinetics, it lower the serum levels. Clinical efficacy, when we talk about the clinical efficacy, there is inadequate response with the initial treatment, loss of response over time. Of course, the safety concerns, there are adverse effects, and treatment survival, there is low treatment survival. And risk of immunogenicity is less in secukinumab and as compared to TNF-alpha inhibitors. Adalimumab has 8 to 39%, and infliximab has 6.1 to 69% chance of development of antibiologicals antibody, while secukinumab has 0 to 0.3%. So there is no reduced efficacy, no safety concerns. Now, the rate of treatment discontinuation, secukinumab versus TNF inhibitors. There is indirect comparison of rate of treatment discontinuation was evaluated. That was a clear study, and that show that the data of TNF inhibitors was derived from cross-sectional study conducted to determine the reason for the discontinuation of treatment. And this discontinuation of treatment with secukinumab was very, very less. That was 0.9% in comparison to infliximab and adalimumab. The incidence of adverse effects, of course, is present in all biologics, but it is very less in secukinumab. The data from Fixture study show that the secukinumab has 55.5% chance of development of adverse effects in comparison to infliximab, that was 82%, and adalimumab 64%. So secukinumab demonstrates favorable safety profile through 5 years. As Dr. Sumit very well raised the point, though the cost is the major factor, but the patient, if under treatment and follow for 5 years, that show that the incident rate of adverse effects with secukinumab is very, very low. So in conclusion, we know that psoriasis is a metabolic disorders associated with autoimmunity. There are different treatments from the topical, systemic, phototherapy to biologicals. Biologicals in India, we have 2 important groups of drugs like the TNF-alpha inhibitors and interleukin-17A blocker. And secukinumab is the first and only interleukin-17A inhibitor approved in India for moderate to severe type of plaque psoriasis. And secukinumab offers superior efficacy than TNF-alpha inhibitors in terms of achieving the PASI 75, PASI 90, and PASI 100 response, improving the quality of life, and require low number of treatments. So secukinumab, is a good options, and even secukinumab also offers better safety profile than other TNF-alpha inhibitors. Thank you.
Thank you, sir, for presenting the slides. And now we have a few questions in the chat box. I think most of the questions has already been answered by different speakers. how do IL-17 inhibitor compare to other biological therapy commonly used in the treatment of rheumatology and dermatology condition? So I think these.
First of all, I would like to thank Sipla for the wonderful and brilliant slides that you have provided to us. It has been a good learning for, at least definitely for me, I think for the other speakers also. The way they have nicely elucidated the whole, the trials in details was really very good. That's firstly. And secondly, regarding this question, how do IL-17 inhibitors, they work compared to the other biologic therapies. So I would like to, I may discuss about the rheumatological part. Firstly, as I discussed already in the psoriatic arthritis, definitely there is one trial, the EXCEED trial, which is a head-to-head trial, compared secukinumab with adalimumab, and in that it has been found, though superiority was not found, was not confirmed at 52 weeks, but definitely secukinumab, as far as where combined ACR 50 plus PASI 100 response was, yes, so combined response was higher for secukinumab than adalimumab at the end of 52 weeks. So it is definitely better. In fact, all the DAPSA remission, PASIS remission, and all the endpoints, secukinumab fared better, but was not statistically significant as compared to adalimumab. The only thing that was better for secukinumab, it had a very high retention rate. So patients tended to persist and continue secukinumab more than adalimumab, which is possibly because of the low rate of infections and easy, like once in 4 weeks, definitely easier and more feasible for patients. Coming to ankylosing spondylitis, I think Dr. Shyamshi Sir will like to say, but I think almost similar results in ankylosing spondylitis also. It comparable. The recent SARPAS trial. I think Dr. Shyamshi Sir will take the question on ankylosing spondylitis comparison between IL-17. You need to unmute yourself.
Yeah, we only have secukinumab in India for use in ankylosing spondylitis as IL-17 inhibitor, and if we compare with the TNF inhibitors, especially adalimumab, definitely IL-17 inhibitors have an edge over TNF inhibitors as in terms of inhibition of progression of radiological damage. It's a very important long-term outcome in ankylosing spondylitis patient. And in all other parameters like improving disease activity, etc., functional outcome, I mean, secukinumab works fairly well. And also one important thing is that infection. Definitely, if you consider infection, especially tuberculosis in India, definitely secukinumab is a very good option. But thing is that those few things you have to keep in mind, because secukinumab is not a very broad spectrum biologic in treatment of ankylosing spondylitis, because it does not work in active uveitis, it does not work in active IBD. So these conditions we have to keep in mind. Otherwise, this is a very good thing, and for long-term use and prevention of radiographic progression in unspun.
Yes.
I think also maximum question has been answered in the in the session.
Mechanism of action has already been answered.
Yes.
Yeah.
It has already been answered.
The slides were so good that I think everybody has answered most of the questions.
Yes.
Yes,
Sir.
And
So
key difference in mechanism of action, it has already been answered. So I think most of the questions has already been answered by different speakers.
Yeah.
So I think on the behalf of Sipla, me and Sumit would like to give my special thanks to all 4 speakers for taking out time and presenting the slides. And sir, please give us opportunity in future as well. We will be conducting this type of meetings again in coming months. And thank you very much for enlightening us with your knowledge. And I would also like to thank all the attendees for attending this webinar. And thank you very much, sir. That's it from my end. Sumit, would you like to say anything?
No, actually, I all done. So thank you so much to all speakers who joined in this meeting, and especially thanks to the all audience who are in this meeting through this HiDoc. And yes, you are right, Kaushal. Next time we will do again. This is the best things to share the knowledge and real case study in front of the all situation in front of the all doctors. Thank you so much, all the speakers, sir.
Thank you, sir.
So we
Good
can
night.
Thank you,
yeah
sir.
we can close right now, sir.
Thank you.
Thank you so
Okay.
much.
Thank you.